Well, thank you very much for joining me this election week for episode number 10 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. If you've had significant interaction with the U.S. healthcare system, you've probably at one point or another wanted to pull your hair out, and that may be part of the reason I'm starting to lose mine. But my guest today is someone who has not been afraid to take on some of these broken and nonsensical rules throughout his career. That's Dr. Sachin Jain. Sachin's the new president and CEO of a creative not-for-profit health plan, the SCAN Health Plan, that focuses on care for frail older adults. Prior to assuming this new leadership role at SCAN, Sachin's held many other important leadership roles. He was previously an executive at the pharmaceutical company Merck, and during the Obama administration, he was part of the team that led the federal initiative to help bring about electronic health records in the offices of doctors around the country. And I'm going to give him a little bit of a hard time on that one because I think we still have some important work to do there. I'll also mention as a point of disclosure that Sachin and I have been good friends since we were both in medical school together. If you do like what you hear today, please do search and subscribe to the Healthy Skeptic MD podcast, wherever it is that you listen to podcasts. Please also search for and subscribe to the Healthy Skeptic MD YouTube channel. So typically I start off episodes with a rundown of the week's health news, but this week, nothing actually caught my attention, maybe because everything's been buried in the tumult of the election. So instead, I want to use a couple minutes to take on a couple comments and questions I've gotten from listeners. So the first topic has to do with colon cancer screening, which is something we've discussed a fair amount in previous episodes. And one listener asked the simple question, should I be screened for colon cancer when I turn 50? And I realized that I've been a little bit casual and nuanced so far in my discussion with that question. So let me begin by saying very clearly, yes, I do recommend colon cancer screening for my patients beginning at age 50, and certainly I plan to do so myself. But one key point I've been trying to emphasize is that we need to be humble here. And as we learned in episode number 5 from Dr. Gil Welch, believe it or not, there's never been a rigorous study that's shown that colon cancer screening helps us live longer, which of course is the ultimate goal of any screening program. The second point I've tried to make is that there's multiple different options for colon cancer screening, all of which are considered to be equally effective. And for example, there's more invasive approaches like a colonoscopy in which a camera is inserted into the intestines, or a less invasive option like a simple stool test that looks for blood as a sign of cancer. And I tend to favor the less invasive approach because it's simpler and there's less likely to be any adverse effects. I think we tend to overemphasize the colonoscopy approach. So the second set of listener questions that I'm going to address relate to episode number 7. Again, that's the episode where we discussed the challenges in the Los Angeles County safety net health system. So we got a great question from a listener. We have this problem of inadequate access to care, in particular specialty care. What's the solution? Do we need more resources in the system? So I'm going to say in response to this that we may need more resources, but even more importantly than that, we need to use existing resources in the most efficient way possible. And that's actually what we're going to talk about today a little bit with Dr. Sachin Jain about how to get rid of some of these broken rules that we have that interfere with care for patients. But in particular, what I think is necessary is a greater focus on the simple things, like, for example, answering the phones and carving out same-day appointments for patients who need appointments right away, and basic customer service. These are all things that go a really long way towards safety net populations. And I think if we've made a mistake, it's that we've overinvested in expensive technologies at the expense of these simple things that really make a difference. So with that, let's jump into our interview today with Dr. Sachin Jain. So I'm happy to welcome to the Healthy Skeptic MD, Dr. Sachin Jain. Sachin is on just about every 40 under 40 list in healthcare, but having gone to his 40th birthday party last week, I think he's going to have to start getting some new awards here. Sachin and I have known each other since we were both in medical school together. I was causing trouble and he was the student council president. So welcome to the show today, Sachin.
Thanks so much, Michael. It's great to be with you. And thanks for coming to my party.
It was a good one. Good 40th in COVID style. So Sachin has worked in a variety of different healthcare sectors. He has worked for the federal government. He was actually part of the team that helped roll out electronic health records to doctors' practices across the country. The rollout has not been as smooth as many had predicted. And having your insights from being involved at the beginning, what have been the challenges and what's needed to right the ship?
Great question, Michael. I would say the biggest challenge has really been around usability. When I worked for David Blumenthal, when he was National Coordinator for Health Information Technology, he used to begin every public address that he would give by painting a picture of a world in which physicians went to work every day excited to turn on their EHRs and use them to deliver world-class patient care to the patients that they served. We are very far from that vision, though I still think that is the vision that we should be striving for. The reason we're far from that vision is that the systems that got implemented were largely implemented to serve the purpose of medical billing. And they weren't necessarily designed to really solve the problems that we as physicians face in the course of taking care of the patients that we serve. That became super apparent to me when I worked at Merck and I was looking to implement various population health initiatives within EMRs. And I went to visit the top EHR vendors across the country. And I realized how really small the clinical voice was inside these companies. The chief medical officer at many of these companies was a sales position, not necessarily a design and program implementation position. And therein lies the problem. These systems have historically been designed to solve the problems of business people within healthcare systems as opposed to solve the problems of clinicians in healthcare systems. I do think that we're at an inflection point. I think that there are skunkworks of organizations that are putting together novel EMRs that are more oriented around solving patient problems than they are oriented around solving the problem of collections. But what I will say is that was the fundamental problem that got miscalculated in the implementation of the HITECH Act and the distribution of Recovery Act dollars that came out of the Recovery Act legislation in 2009.
Well, I certainly agree with you. I think, as you said, many of these EHRs were built for business purposes, for billing, and not necessarily with patients and doctors in mind, and with solving our challenges. So, a related question. People are saying in the same way that they did with electronic health records that artificial intelligence and some of these health apps are going to revolutionize healthcare over the next decade or next 15 years. You're going to lower costs. Maybe they'll even replace doctors and nurses. I've heard that said. Any predictions on that?
I don't think doctors and nurses are going anywhere. I think at the end of the day, artificial intelligence can be used to augment the clinical care that patients receive, but it's certainly not going to be used to replace the clinical care that patients receive from physicians and nurse practitioners. It might in sort of simple use cases where there are single problems that need simple solutions. But I would say one of the things that is very evident about medical care, if you've ever delivered it, and hopefully if you've ever received it, is that it's very humbling. A headache is not anything until you actually get into the story with the patient and really understand what the underlying condition is, what's been happening to the patient outside of their current symptoms. And that context setting is a function of understanding the patient's clinical condition, but it's also a function of understanding their social condition and understanding what else may be going on in the life of that patient. I think artificial intelligence can be helpful in some specific use cases, but I would say the days of Star Trek are really 30 to 50 years away. But in the immediate future, we're going to still need doctors and nurses who are compassionate, loving, and caring, who actually take a lot of pride in serving and taking care of patients.
Yeah, I think humility is a good way to put it. All right, well, let's shift to what you're up to now. So you recently became president and CEO of SCAN Health Plan, which is a California health plan, but it really has a national reputation. Tell us a little bit about SCAN.
Yeah, SCAN was founded in 1977 by a group of people we affectionately refer to as the 12 Angry Seniors. These were 12 individuals who got together and said, there's got to be a better way to do senior care. There's got to be a better way to do aging. And they came together with a simple goal of trying to keep seniors healthy and independent. this, for me is a timeless goal. I've worked now in the senior care space for, more than a decade. And ultimately, got to work doing some really innovative things, first as a social HMO. And then after that program was sunset, as a Medicare Advantage plan. And now, our board has asked us to think about other ways that we can fulfill the mission beyond just a Medicare Advantage plan. And so we're looking at other means of fulfilling our mission, looking at innovating around primary care, behavioral health, pain management for seniors, taking a look at the unmet needs that exist in the senior population, whatever they are, however big or small they are, and setting an aspiration to solve some of those biggest, thorniest problems that I think have gone unsolved for generations for all kinds of reasons. So very excited to be joining the team at SCAN. We've got our eye on both regional as well as national expansion and diversification, and couldn't be more excited, couldn't be more thrilled to be here.
So I recently had on the Healthy Skeptic MD, New York Times bestselling author Katie Butler. She's written a lot about the mismatch between care that geriatric populations get and what actually aligns with their goals. She talks about excessive care, but then not getting the simple things that really make a difference. How is SCAN Health Plan going to try to take that challenge on?
One of the most, I think, amazing things about SCAN is we work, in risk-based healthcare. And I think a lot of people talk about value-based healthcare. SCAN's done it throughout most of its history. And what that allows you to do is take a total cost of care view of a patient and think differently about their care and the solutions that you need to bring about to actually solve their problems. As a result, we're able to introduce innovative benefits around the social determinants of health, around food insecurity, around transportation, things that traditionally are not necessarily thought of as healthcare. Now, lots of people in this industry are thinking about these problems. Lots of companies are introducing new benefits. But I would say some of what I think distinguishes SCAN is our culture and our focus on getting the right things into the hands of patients. Again, I think we take a full look at the complexity of what it means to be a senior in America in 2020, what your needs are, what your unmet needs are. And we try to think holistically about who you are and what your challenges are. I was privileged to be one of the first people to launch a national conversation around social isolation in seniors several years ago when I was working in a prior role. And, especially in the midst of COVID-19, this is a theme that is, incredibly important, incredibly resonant. What was, thrilling about joining the team at SCAN is we already had a whole infrastructure in place to address these issues. We employ a number of our own members, in fact, to actually make outreach calls to other members to ensure that they're doing okay. And for many people, the call that they get from SCAN is literally the only call that they get from anybody because of the nature of how aging has changed in American society. So what I'm proud of, what I'm excited about, what I'm optimistic about is a view that we can actually solve some of the social challenges that historically have gone undersolved by healthcare organizations. That said, I'm very, careful because this is not a single sector problem that we have to address. I think sometimes our industry tends to want to take everything and put it under our tent. You get involved, Mike, in conversations where people say, oh, healthcare organizations need to fund housing. I'm not quite that radical in my perspective, but I do believe healthcare can be the hub for accessing the broader social safety net. And that's where I think an organization like SCAN is uniquely positioned to do, well by its members or do right by its members is that we're able to kind of create those connection points that otherwise don't exist.
Yeah, the loneliness that's been happening during the COVID pandemic it's really been heartbreaking. And, I'm a primary care doctor and I've seen some people very sick, but really some of the most tragic stories I've seen, situations I've seen are older people who have essentially no interaction with the outside world, except for me as their doctor and whoever's delivering their groceries. So it's such a big problem. I want to talk a little more about COVID. Another guest I had recently, Dr. David Katz, has made the case that our society has not done well by our geriatric population during this pandemic. His view is that we have overreacted to the health risks for young people. We've kept schools closed and so forth. But by the same token, we have not done enough to shelter and protect and provide the resources for the older populations, as evidenced by the outbreaks in some of the skilled nursing facilities, the nursing homes, and so forth. Do you agree with that assessment? And if so, do you have any perspective on what we could be doing better?
I couldn't agree more. I mean, I within my own family, and as well as, kind of the patients that we serve at SCAN and also in my prior role, I can tell you one of the biggest challenges that people are experiencing is social isolation. And we created these draconian rules in senior living facilities that don't allow any visitors. And as a result, you have a number of folks who are, I think, both subject to infection that's introduced by staff who kind of come and go, but then also don't have the benefit of actually seeing people who they care about. And I will tell you that we're in kind of a highly atypical moment. There is probably opportunities to actually rethink how we cared for folks. There's this now what they're calling kind of the Pace Without Walls movement to actually help people with added support within home situations where they may have access to family. I think we as a country needed to start a dialogue very quickly that we failed to initiate around, where do we put seniors right now in this time of great vulnerability to keep them safest and healthiest and most connected. And I don't think it's in nursing homes where they can't see family or friends. At the end of the day, if you have nothing to look forward to, you begin to have, a pandemic of a different kind, pandemic of social isolation, the deterioration of one's will to live. And there, we all know, I think that is a common phenomenon in 2020, is that there are a number of folks who, whose entire reason for living and continuing to live is connecting with others, seeing that grandchild born, attending that family event. And because we rob people of that, we've now gotten into a situation where I think many people are questioning whether they want to continue to live. That's the despair that we start to see, emerging among the geriatric population. So I think this notion that social interaction is a foundational part of life needs to be drilled into healthcare facility operators and owners, and the design of systems should incorporate social interaction and social care, and not necessarily ignore it in the way that it's been ignored. So I couldn't agree more.
Yeah, you mentioned the PACE program. A lot of the viewers may not be familiar with that. It's Program for All-Inclusive Care for the Elderly. That was actually really not a healthcare movement. That was something that was a social movement where healthcare became part of it. The Chinatown community in San Francisco came together and said, we're not doing a good job of providing that those social connections that our elder members need, and they wrapped everything together as healthcare and social services and physical therapy, and it became a national model that spread. The problem with PACE, of course, is it's a very expensive model. So this idea that you're talking about a PACE without walls, how do we create an integrated network for older people and ensure they get the healthcare? That'd be a great challenge if it's something that SCAN could take on.
Yeah, I mean, within this whole theme of healthcare cost containment, cost management, I think is embedded a topic that I know is really near to your heart, Michael, which is the notion of sensitivity and specificity, and making sure we're layering interventions onto people, who are most likely to benefit from it with a high degree of reliability and validity, right? And we say things are expensive, but ICU stays are expensive, and hospital stays are expensive. I always ask people whether they know, how much the average hospital day costs in Southern California, and it's somewhere on the order of $3,000 to $3,500 a day. You can buy a lot of social interventions and healthcare for people for $3,500 a day. And so, again, the issue is making sure you're getting it just to the people who really benefit from it, and where you can actually create a cost offset. And that's where I think AI and machine learning and some of the tools that we referenced earlier in the podcast actually can make a really big difference, which is getting better and better and better at targeting who would benefit from a very high cost intervention like PACE.
All right, so I want to skip to another social challenge that you've written about recently, and that's homelessness. Here in Southern California, it's really heartbreaking, the rise. In Los Angeles County, we're at more than 60,000 people living on the streets. Just tell some of the listeners who are not from Southern California a little bit about LA and what we've experienced with homelessness.
Yeah, I mean, Los Angeles County is like a lot of counties in the United States today, which is that we have a growing population of homeless Americans. These are people who, have found themselves in a state of health or mental well-being or addiction, such that, or poverty, such that they end up in a place where they can either no longer afford to have stable housing, or they aren't able to maintain, for other reasons, a place for themselves in stable housing. Los Angeles is full of incredibly passionate physicians, social servants who take their talents to the streets to serve people who need their service. And I think it's incredible. And my career actually began in homeless healthcare. You may recall, Michael, from our medical school days, I was involved with a group of students, Louis Shee, Vanessa Carey, Tamara Oe, and others, in starting when I was an undergraduate, a health clinic for homeless individuals in Harvard Square. It was one of the most remarkable educational experiences of my life that has stuck with me throughout my career. And one of the things I've realized is that as I've gotten deeper and deeper into the world of healthcare finance, even as I've remained a practicing physician, is the fact that a lot of progressive financing mechanisms like Medicare Advantage can potentially provide additional dollars for the management of care for homeless individuals, which could then lead to better housing outcomes for them as well as better health outcomes for them. We actually recently did an analysis of SCAN data and looked at 150 or so individuals we knew were homeless within the SCAN data. And we found that they all had RAF scores. These are risk adjustment factor scores of 2.1 to 2.5. And what that means is that Medicare pays a certain multiple to health plans like SCAN, to take care of these patients, the multiple between 2.1 and 2.5, which translates into, roughly $25,000 to $27,000 per patient per year. You can do a lot for an individual for $25,000 to $27,000 per person per year. The issue is that most of that money goes to pay for inpatient hospitalizations or emergency room visits, because that is how most of these patients traditionally access healthcare. They're on the street, they experience an injury, or they have an exacerbation of an underlying medical condition. They find themselves in an emergency room, they get admitted, and then the health plan is paying, some number of dollars to the medical organization to actually take care of those patients. Myself and John Backus, who's the CEO of LA Care, along with Jim O'Connell, who's the founder of Boston Healthcare for the Homeless, took a big step back last year and started to ask the question, what if we took that $25,000 to $27,000 and actually gave it to a healthcare organization and said, keep these patients healthy, keep them housed. Now, the topic that's particularly interesting to me in my role now at SCAN is this issue of homeless seniors, which is a growing problem, both because of the economic insecurity and the deterioration of the social safety net, as well as the prevalence of addiction and mental illness in that population. So the question is, for those individuals on the street who are Medicare eligible, either through disability or through age, is there an opportunity to take this $25,000 to $27,000 and allocate it differently than we're allocating it today? Today, we allocate it to medical providers, primary care doctors, specialists, and hospitals. What if we were to take that $25,000 to $27,000 and say, maybe I'll provide some transitional housing assistance. Maybe I'll provide folks with a higher degree of intensity around their behavioral health management, or treat their addiction. All of a sudden, you start to see a potential path to Medicare being a potential solution to the homelessness problem.
Well, one precedent is actually the PACE program itself, which you mentioned before. They got some waivers and approvals to use healthcare dollars for non-traditional medical services. I previously worked in a PACE program. I remember I had an older woman during the summer who kept getting admitted to the hospital with heat stroke. And we did the crazy thing. We bought her an air conditioner, and after that, I don't think she had any further hospitalizations. And under a traditional Medicare model, believe it or not, that's not allowed. I don't think that you really have to use your dollars for traditional medical services. And if we could just think a little bit more broadly outside of the box, I could see a real opportunity.
Yeah, what you just described is what I like to call radical common sense. It's radical because in our industry, something so common sense as buying a $350 air conditioner as opposed to paying for an inpatient hospitalization is not something most healthcare financing mechanisms allow. But one of the great things about working in risk-based healthcare, whether it's PACE or Medicare Advantage, is that you do potentially have those opportunities, provided you have the right regulatory frameworks to enable it. And so, again, I think that this notion of radical common sense, homelessness, thinking about creatively about dual eligibles, Medicare finance, Medicaid finance, putting all these pieces together to then potentially house some individuals, potentially provide more intensive medical interventions to individuals, starts to suddenly look pretty interesting.
Curious your take on the housing first model. And for the listeners, housing first means someone gets admitted to the hospital, they're homeless. It's clear that's a key driver of why they keep ending up there. And rather than necessarily focusing on every medical issue, the first step is to get them housed and to use the healthcare system as an entry point to get them connected with that housing. What's your thoughts on that?
So I have super mixed feelings about this, not because I don't want people to get housed, but because I think it's one of these examples of where the healthcare system ends up shouldering more than it should. And it sometimes becomes a distraction from, addressing, some of the issues that it should be addressing. Frankly, you see lots of pilots of this kind of housing first type model. And we get really excited when, X county or X, corporation announces that it's going to provide 100 or 200 or 500, housing units, which is incredible. But at the end of the day, it's a drop in the bucket. And I think we need to think differently about this issue. And I don't know that we have empiric evidence of what happens when you actually treat the underlying conditions that ultimately lead people into homelessness. Sometimes it's an underlying medical problem. Sometimes it's an underlying addiction issue. Sometimes it's an underlying behavioral health issue. I think the question is what do you do first? In some cases, I do think getting someone housed will be the solution. But I think in other cases, dealing with the underlying addiction or behavioral health issue up front may be the thing that allows them to get housed, allows them to reconnect with, the other social safety net that we don't talk about a lot, which is people's families, where people fall out of favor. And so, again, I think that it's a both and type of situation. And I think this is one of these places where I think our political activism kind of leads us to some funny places, which is, I don't think any rational person would ever say it's just housing or it's just medical care. But sometimes the conversations get so polarized because people are very agenda driven in these conversations. I think it's both and we've uncovered a mechanism through Medicare Advantage to really drive better medical financing and potentially build richer medical models for folks that I think could lead into, better housing models. Let's take a look at all of it, and not get too, I think, overly fixated on one approach or the other.
Well, my concern with the housing first model is just a very practical one. Our local leaders here in LA County developed a model, and it worked great for the first couple months. And after the first 30 or 50 patients that went through it, there was no housing left.
That's exactly what I'm talking about. And again, it makes us all feel good that we've done something in it, and it puts, you can write some great journal articles and you can write some great op-eds. But Mike, I think the real issue is like, how do you solve this problem end to end, not just make ourselves feel better for a little while?
Yeah, and I actually think a key piece of it is mental health. Not that there's an easy solution to that, but at least in my experience, that is a driver of a lot of the people who are there on the streets. Well, let me ask you one final question while we have you today, Sachin. You proposed the idea of specialized health plans for homeless populations. Tell us a little bit about what your vision is there. What would that look like?
Yeah, I mean, I think it's this idea that I've started to sketch out, in the podcast already, but it's this idea that Medicare Advantage would take Medicare Advantage organizations that want to solve homelessness would apply for special designation to CMS. They might get some additional risk adjustment for housing insecurity, which I think is even if it's not a recognized recognized adjuster to the revenue base for Medicare Advantage, it should be, and would ultimately then kind of have to file a model of care with CMS that would include some version of providing enhanced social support, some version of providing enhanced clinical support, and then these Medicare Advantage plans would then delegate those dollars to medical groups that were interested in managing the total cost of care, and they would be responsible for paying hospitalization, specialty costs, primary care costs, and so would be incented ultimately to keep patients out of the hospital, which ends up being the most expensive line item for folks, and would be incented around managing behavioral health and addiction issues for these patients. And so I think that that's the opportunity here, is to enroll a number of individuals a number of homeless individuals into Medicare Advantage plans, only to then have the medical groups that were taking care of them not want to care for them because they couldn't do things like provide colonoscopies or mammograms, which are kind of key quality measures that against which Medicare Advantage plans are judged. So again, part of it would also include some waivers around kind of traditional quality measures and introduce new ones for individuals who are homeless, that could then be used to really support a higher quality care experience for these patients. So again, it's a bit of a pie in the sky idea. It's one that I'm super committed to and passionate about. Sort of 2 years into trying to make something come of it, presenting it in a couple of weeks to the SNP Alliance, Special Needs Plan Alliance, which is a group of health plans that have special needs plans, of which a homeless health plan could be another flavor. And we'll see what happens. These are exciting times around innovating around the social determinants of health. Hopefully, there's a tolerance at CMS in either a Trump or a Biden administration around this. I think one of the neat things about homelessness is it's proved to be a bipartisan issue. You see folks on both sides really being quite upset about it, and I think that creates a lot of opportunity for social entrepreneurs to begin to think about solving this issue.
Well, thank you so much, Sachin, for joining me today. This has been Dr. Sachin Jain, the new CEO and president of Scan Health Plan. If you're not familiar with them, check them out, because I think they're going to be a really interesting group to follow in the months and years to come. If you did like what you heard today, please search for us wherever you listen to podcasts. You can also find my YouTube channel. It's healthyskepticmd. Thanks for joining, and we'll catch you again next week. Thank you.